The learning objective of Lesson 4 is to understand the meaning of the second group of Bradford Hill criteria and how they apply to pharmacovigilance. Consistency is also one of the criteria. It means that reports are received from a range of reporters or, in international databases, a range of countries, and there are similar observations in the reports. If reports are from only one source, it will be important to decide if there is a local problem with the medicine, such as a batch difference or poor storage, etc. If not, then a lack of similar reports from elsewhere reduces the likelihood of a causal association. Then we come to biologic plausibility, which means that the suspected reaction fits in with what we know about the drug's actions. However, we may not know that the suspect drug can act in a way that causes the adverse reaction, especially if it's newly marketed. For example, tendinitis with ciprofloxacin was unpredictable. Therefore, the criterion is supportive if it is present, but it is not a strong requirement for causality. Here's an example of biologic plausibility. We know that anticholinergic drugs may cause urinary retention because the bladder outlet sphincter can't relax normally. It's most likely to occur if the bladder outlet is already compromised, for example with an enlarged prostate gland. If a new drug is reported to cause urinary retention, if it has some anticholinergic activity, then the retention is biologically plausible. Now we come to coherence. Does the suspected reaction fit with existing knowledge? For example, we know that furosemide can cause loss of potassium. If it isn't being very effective in a patient, it might not affect the potassium levels at all, but it can't retain potassium. So if you have a report of furosemide and high blood potassium levels, it is highly likely that another medicine being taken is the cause, such as spironolactone, or that the patient may have developed renal failure leading to high potassium levels. It would also not be coherent with existing knowledge for a drug that is not absorbed from the gastrointestinal tract to cause organ damage. A dose-response relationship is good evidence of causality, but it might not be observable in some situations. For example, the very small doses needed for an immunological adverse reaction are considerably below the therapeutic dose of the drug, and so any dose response will not be observed with normal clinical use. When we think about specificity, we consider the terms used for the suspected adverse reaction. Many adverse reactions have multiple causes, for example, headache, abdominal pain, renal failure. Generally, drugs cause adverse reactions through specific mechanisms, so that an adverse reaction is more likely if a specific cause of the condition is reported, such as interstitial nephritis occurring in the reports of renal failure. We also consider the drugs. Are a number of drugs suspect? There is much stronger evidence for causality if it is just one or two. Then we come to experimental evidence. This may be from previous animal or human studies. For example, many drugs are now checked for prolonged QT interval. Analogy is when similar reactions have been observed with other members of the suspect drug's ATC group. For example, combined oral contraceptives and venous thrombosis, angiotensin-converting enzyme inhibitors, and angioedema.